Today we will be discussing about cardiomyopathies. Cardiomyopathies are a special group of myocardial dysfunctions, right, in which there is defect primarily within the myocardium, right. Now, to make the concept clear about cardiomyopathy, right, or diseases of the myocardium, you have to remember that there are certain conditions which should be excluded, right. For example, myocardial damage due to high blood pressure, hypertension, myocardial damage due to coronary artery disease, or myocardial damage which is due to valvular heart disease and congenital heart disease, and then we can talk about inflammation. These 5 conditions are not included in cardiomyopathies. When there are myocardial damages related with hypertension, or myocardial damage related with coronary artery disease, or myocardial damage secondary to valvular heart disease, or myocardial damage related with the congenital conditions, or myocardium is inflamed. When actively inflamed, all these conditions are not included in cardiomyopathies, right? It means that cardiomyopathy is due to some intrinsic defect in myocardium or some disease which lead to primary abnormality within the myocardium, which is not due to hypertension. Again, what is cardiomyopathy? Cardiomyopathy is pathological conditions of myocardium which are not due to hypertension, not due to coronary artery diseases, not due to valvular heart diseases, not due to congenital heart diseases, and in which myocardium is not actively inflamed, right? Primarily, cardiomyopathies are divided into 3 groups. Primarily, cardiomyopathies are divided into 3 groups, and these are dilated cardiomyopathy, hypertrophic, cardiomyopathy, and there is restrictive cardiomyopathy. Restrictive cardiomyopathy. There is dilated cardiomyopathy, there is hypertrophic cardiomyopathy, and there is restrictive cardiomyopathy. In a simple diagram, let's see how they are different from each other. In dilated cardiomyopathy, what really happens that left ventricle is pathologically dilated, or even right ventricle is also pathologically dilated, right? Dilating cardiomyopathy, which is also called congestive cardiomyopathy. Dilated cardiomyopathy is also called congestive cardiomyopathy. In this case, what really happens that myocardium become ballooned out. It's pathologically dilated, and this pathologically dilated myocardium cannot contract well. It cannot contract well. There is global hypokinesia of the myocardium. There is global impairment in the movement of myocardium. Hypokinesia means movement of myocardium. There is global impairment in the contractility of myocardium. If you want to remember in single sentence, there is global impairment in the contractility of myocardium, usually left ventricle as well as right ventricle. Is that right? It is slowly contracting, poorly contracting heart, or we can say it's hypokinetic heart. It is large but hypokinetic heart, and of course it's a failing heart. And this failure will be diastolic failure or systolic failure. It is not diastolic failure, because during the diastole it can accommodate the incoming blood, but during the systole it cannot contract well. So this is basically a systolic failure. Dilating cardiomyopathy which is right ventricular and left ventricular both. Both ventricles become ballooned out. They, like a balloon, they enlarge, they become very poorly contractile chambers, and we say that dilating cardiomyopathy is a condition in which there is biventricular failure with pathologically dilated both chambers. And remember, this global impairment in contraction, because if there is only segmental impairment in contraction, that may be ischemic heart disease. But in cardiomyopathy, dilating cardiomyopathy, there is global problem throughout the myocardium. Is that right? So this is clinically coming as systolic failure. Systolic failure, failure of contraction. The real problem is systolic failure, and patient will develop, right? Now, opposite to that, hypertrophic cardiomyopathy is different. Hypertrophic cardiomyopathy is different. In this case, there is pathological hypertrophy of myocardium. Let me explain that. Let's suppose this is the normal left ventricular chamber. Suppose this is the normal left ventricular chamber, and here is your aortic valve. Here is your aortic valve. Now, when it undergoes hypertrophic cardiomyopathy, it develops pathological hypertrophy, and especially this hypertrophy is very pronounced in septum. Other part of myocardium is only mildly hypertrophied, but septum, interventricular septum is grossly hypertrophied, very severely hypertrophied, and especially in this case, which part of the myocardium is hypertrophied more? Septum. Which part of the septum? Upper part of the septum, right? Now this septal hypertrophy, right, it has a very special type of hemodynamic problem. Look here. Ventricle will contract strongly because there is more muscle. It will contract strongly. It is hyperkinetic heart. It is hyperkinetic heart. Remember, dilated cardiomyopathy was hypokinetic. This is hyperkinetic. But there is one problem. Look here. Please attention here. You know, whenever ventricle contract, septum becomes shorter. Septum becomes shorter. And when septum becomes shorter, this obstruction bulges in the cavity. This obstruction will bulge in. During every systole, this obstruction, especially in 30-40% of these patients, this obstruction dynamically during the systole or contraction bulges into cavity. And when it will bulge further into cavity, it will produce an obstruction to outflow. It will produce an obstruction to the outflow, right? So it is not normal hypertrophy. You know, hypertrophy is seen in hypertension disease. Hypertrophy is seen in aortic stenosis. That hypertrophy is usually symmetrical hypertrophy. Symmetrical means that hypertrophy is equal in all parts. For example, if I'm having hypertension, right? Let's suppose someone has hypertension or he has aortic stenosis, then hypertrophy will be equal and symmetrical in all part of myocardium. So this type of hypertrophy is called symmetrical hypertrophy, where cavity remain oval or ovoid. But in this particular condition, the hypertrophy is asymmetrical. So some people call it hypertrophic cardiomyopathy as asymmetric cardiomyopathy. We call it asymmetric hypertrophic cardiomyopathy. Asymmetric. This point is very important because septum is too much hypertrophied as compared to the remaining myocardium, and during contraction, when septum shrinks, right, then this obstruction become more pronounced, because when it will shrink in this way, it will bulge as a big obstruction to the outflow. Because it produces outflow obstruction, this is very commonly called hypertrophic obstructive cardiomyopathy. Another name is that there is hypertrophy which is leading to obstruction. Hypertrophic obstructive cardiomyopathy, or simply call it obstructive hypertrophic cardiomyopathy. Is that right? Now, can you confuse these two conditions? These are very different. This is poorly contracting heart. It is vigorously contracting, strongly contracting heart. Here on echocardiogram, you find a very big heart with a very big cavity, is that right? And usually thin-walled myocardium. And myocardial contractility is poor throughout all elements of the wall. But when you check this hypertrophic cardiomyopathy on the echocardiography, number one, you find there's hypertrophy. And number two is more important than number one, that hypertrophy is asymmetrical, especially septal hypertrophy is more pronounced than the free wall hypertrophy of the ventricle. Thirdly, cavity of the ventricle is abnormal. It's something like banana shape. You can look at this cavity, it's something like banana shaped cavity. So this is abnormal. You can say that cavity of this is right. This is banana shaped cavity, right? Right. Now this is balloon like, this is banana shape, is that right? Now these two I hope you will not confuse. Now we come to the third type of hypertrophy, and in third type of hypertrophy, first you look at the ventricle. In third type of cardiomyopathy, what's wrong? That there are pathological infiltrations. There are pathological infiltrations in the, what is this? Myocardium. And due to this pathological infiltrations, myocardium become firm, and the real problem is failure to relaxation. The real problem is, I should write it here. In this case, the real problem is failure to relaxation. Failure to relaxation. Right? That during this is, look at it. Due to infiltration, this become thickened. It is thick myocardium, right? And this myocardium, which is thick, right? It failed to relax properly. It failed to relax properly. And because it does not relax properly, do you think during diastole it will fill properly? No. So it will lead to a problem during the diastole. That function of the myocardium is that during systole it should contract well, and during diastole it should relax. Normal function of the myocardium is during diastole it should relax, so that incoming blood can be accommodated, so that it can be pumped in the next beat. But the problem is this, here the left ventricle or ventricular wall is infiltrated with some, for example, like amyloid material abnormal protein, or infiltrated with sarcoid granulomas, or infiltrated by, you can say, what is this, hemochromatosis, iron overloading conditions. So if there is some pathological infiltrations and myocardial wall become thick and firm, and it failed to relax during diastole, it will lead to diastolic failure. It will lead to what type of failure? Diastolic failure. So on echocardiography, because one of the best way to diagnose is echocardiography. In echocardiography, in dilated cardiomyopathy, you find that ventricles are ballooned out and thinned out, right? And they are very poorly contractile and leading to systolic dysfunction or systolic failure. Is that right? Hypokinetic heart. When we talk about hypertrophic obstructive cardiomyopathy, this is the second group of the problem. What's wrong with the second group? That is pathological, asymmetric hypertrophy of the myocardial ventricular walls, and the maximum hypertrophy is seen in the interventricular septum, especially in its upper part, right? And the main problem here is not contractility. Main problem is abnormal dynamics of contraction due to outflow obstruction. Is that right? The real problem is not the contraction, right? Contractility is okay, but contractility becomes abnormal due to abnormal cavity and due to an element of dynamic obstruction. You know, if there's aortic stenosis obstruction, that is called fixed obstruction. But when the septum it bulges into cavity, and during systole, when it bulges in the cavity, even mitral valve also hit here. So both of them together, they act as outflow obstruction. That is why this asymmetrical hypertrophy, which is leading to outflow obstruction, left ventricular cavity outflow obstruction, is also called hypertrophic obstructive cardiomyopathy. Okay, there's only one sentence. If you want to remember only one sentence about this condition, let me tell you. This type of cardiomyopathy is 50% cases are familial, but 100% cases have genetic defect, mutation. 100%, almost 100% patient have genetic defect. I will explain it later. Out of this, 50% cases are familial and 50% cases are sporadic. For example, if you have 100 patients with hypertrophic obstructive cardiomyopathy, in 50% patients you will find a family history of such problems, and 50% of them you will not have the family history. It means there is also mutation here, but this mutation is a new mutation. This is a new mutation, and this is a mutation which is inherited generation after generation. It is autosomal dominant. Autosomal dominant means that out of two alleles, even if one gene is defective, disease will be there. Is that right? Out of, one gene come from mother and other set of gene come from father. Even if one set of gene is defective, disease will be there, right? So what we really see here, that it is 50%, almost 100% cases have mutations. Out of them, 50% have inherited mutations, 50% are sporadic cases. But yet the most important sentence is not there. The most important sentence related with this is that the most important concept related with this is that this is a cause of unexplained death in the young athletes, especially in the boys.
Familial?
Yeah. In some family, maybe your mother tell the young boy, please don't play too much. Don't play, do the aggressive athletic activity. Your father died in the ground suddenly, right? But boys, boys don't listen when they are adolescent. He may go into vigorous activity, right? And he may suddenly one day collapse on the ground and die at the spot. And later on autopsy, you will find that there is hypertrophic obstructive cardiomyopathy. This is the most common cause of sudden cardiac death in young athletes during the vigorous physical activity. Right? This is the most important cause. What is the reason? The reason being when they are doing a lot of physical activity, is that right? Heart become more dynamic, and if heart is becoming more dynamic, obstruction become more pronounced. And when obstruction becomes more pronounced, it becomes more difficult to eject. Is that right? And during the physical activity, not only if obstruction is more pronounced, it means outflow will be less and aortic filling will be less. Pressure in aorta will drop. And very severe exercise with obstruction, right? Obstruction which has increased in dynamicity as heart rate goes up. Aorta is overfilled or underfilled? Underfilled. At the top, when he is doing physical activity, most of the arterioles will relax. So whatever blood is here, it will be stolen away by the peripheral system. So very little blood is left to perfuse coronary artery. So when they do a lot of physical activity, the cardiac output drops, because during severe physical activity, when sympathetic nervous system is more active, heart rate goes up, obstruction becomes more dynamic, outflow becomes less. At the top, during physical activity, most of the muscles, blood vessels relax, arterioles relax. So blood will wash away to less resistant areas. So there will be more blood flow to the muscles. Pressure in the root of aorta is less, very little blood going to the myocardium. This may precipitate severe ischemia and conduction abnormalities and fatal cardiac arrhythmias. So what really happens to this patient? That patient may undergo fatal cardiac, ventricular of course, arrhythmias, and death may be there at the spot. So I hope first and second case you will not confuse, right? In third case it's entirely different. Problem is that ventricle failed to relax. The ventricular wall is thick. Here size is almost normal, but ventricle is thick, firm, failed to relax during diastole, failed to accommodate enough prelobe, failed to accommodate enough end-diastolic volume, right? And that will lead to back pressure. Is that right? Let's have a break and then we'll continue.